I almost applied for an internal medicine residency so that I could be a gastroenterologist, and then I really thought about it and I decided not to. I talked to my wife and I said, so what are you gonna tell people when they ask what I do? You know, because all you do is a GI is you scope people and check their bums, and so we had that conversation. I changed my mind. So let's get into GI. Off though, yes. Yeah. Yes. Yeah, you're absolutely right. They always say that the eye is the window to the soul, and it's certainly the window to someone's medical record, because diabetes, lupus, hypertension, so many things you can see in the eye. Very interesting subject. So development-wise, we got to talk a little bit about embryology. The GI tract is really one of the most primordial things. If you want to get simplistic with it, all we are is really just a tube where we put food out in one end and everything out comes out the other end. That is sort of the simplest version of what we are. And in development, that is fully represented, where the first thing to happen is for our GI tube to form, essentially. Now, as it's forming, it forms in three sections: a foregut, midgut, and hindgut. The foregut is everything from our pharynx to our duodenum. And you'll see that, as we move into the GI, that's all supplied by the celiac artery coming down here, providing, to the greater curvature of the stomach, and all the way up to the first part of the duodenum. Second and third parts of the duodenum, all the way to 2/3 transverse colon, is supplied by the SMA, and the hindgut supplies the distal 1/3 of the transverse colon to the anal canal above the pectinate line. That's for the IMA. And so, we can be talking about arteries here, but we can also be talking about the sympathetic supply. And so there's the celiac plexus that provides sympathetics to our GI tract in the area of the foregut. There's a superior mesenteric plexus that provides sympathetics to this part of our midgut, and an inferior mesenteric plexus that provides it to the hindgut. And so if they really want to send you a tricky question, what they're going to do is ask you, what is the innervation of the distal duodenum? Okay, and you're going to say, well, that's something I never memorized, but I know that the blood supply is SMA, and so my best bet is the superior mesenteric plexus also provides the innervation to that area. Some of the derivatives, our esophagus forms from the tracheoesophageal folds. The tracheoesophageal fold will create our trachea and esophagus, right? It's right there in the name. And this is important for some clinical considerations. Esophageal atresia is when those ridges deviate too far dorsally, and so we end up with a closed tube for our upper esophagus, and the gut can actually connect to the end of the trachea and allow gastric contents to enter the lungs and air to enter the stomach. Okay, and so there's a number of different types of tracheoesophageal fistulas, TEFs, and we're going to discuss those in time. But essentially, they are all due to this common trigger, which is when those tracheoesophageal folds fold in to divide the two, they don't do it in an appropriate way. Congenital hiatal hernia is when the esophagus does not grow long enough. In terms of the stomach, here we have a dilation of endoderm in the foregut, and this undergoes a 90-degree rotation, kind of giving it that shift that you see in the adult stomach, right? The adult stomach sort of has the greater curvature down here and the lesser curvature closer to the diaphragm. That is due to a 90-degree shift that happens. This also moves some of the vagus nerves, anterior and posterior. I had a question one time on where is the vagus nerve in relation to the stomach. I missed that question, I can tell you right now, but I definitely included that fact in this lecture just because I got that question and I missed it. And so if you ever get that question, it's not particularly difficult to remember if you remember that this orientation is also true at the level of where the esophagus goes through the diaphragm. Okay, the left vagus is anterior, the right vagus posterior, as the esophagus goes through the diaphragm, and that holds true as you get to the stomach. Okay, so what about clinical considerations? So there's this condition called hypertrophic pyloric stenosis. What is this one about, Bob? Can you tell me a little bit about pyloric stenosis? Yes? Wow. Well done. I'm going to have you take over from here, Bob. That was great. Really interesting. Of course, so yeah, so you end up seeing quite a bit of it. Interesting. Wow. And you mentioned something really important, which is that you don't see this at birth, right? You see it usually 2 to 6 weeks. That is what they like to test on. That is what they like to get after and make sure that you know that this is not going to be something present at birth. If an infant is vomiting at birth, cross out pyloric stenosis as a possible answer choice. Is it possible in reality? Yes, anything is possible in reality. For step 1, that's not going to be the case. Okay. Excellent. Great. Great. Yeah. Nothing else I could say. Bob covered it. So liver, we have emerging from endoderm. Pancreas starts as 2 growths. We get a ventral bud and a dorsal bud, okay? And so one's ventral, one's dorsal, so one's in the front, one's in the back. And what happens is that the ventral bud rotates around to meet the dorsal bud. The dorsal bud rotates a little bit as well, and you end up having, instead of having one bud here on one side and then another long bud on this side, you get a little bit of rotation by each. They come together, and so the ultimate formation of the pancreas is something like this, I can say, okay? And you get something called the uncinate process, I believe, is what this small little dangling portion of the pancreas is called. And so this is a normal development, and the formation of ducts within the pancreas should, typically there should be one duct. Sometimes there's an extra accessory duct, but in general, you just have one duct. That's the important thing. Now, when there's that rotating going on, there are cases where rather than this bud just moving as one unit, sometimes the front of this bud will move, but the back will stay in place. So then rather than just having this nice one thing rotating, you end up getting this strip of pancreas that forms around the gut tube, okay? And then on the other side, you have another strip. And so you end up having an annular pancreas that completely 360 degrees wraps around the gut tube and can obstruct the movement of food particles and chyme and everything else through the digestive system, okay? Now, important things about this, you're going to see vomit, except that vomit may be bilious. It may not be bilious. It depends on whether bile is able to exit through the sphincter of Oddi and into the digestive tract. If it is, you're going to get bilious vomiting. If it's instead emerging post obstruction, you're not going to have bilious vomiting. So that is not a total requirement. But one thing that you may look for is the lack of a palpable knot in that epigastric region. Okay, great. Now, some developmental defects. We have our gastroschisis and omphalocele. Probably the funnest disease to say in medicine, omphalocele. So these can be due to either a lateral fold closure or a caudal fold closure. Or caudal fold closure has to do with the bladder, excuse me. For the lateral fold closure, you can either have the omphalocele or gastroschisis. The big difference between these two is whether or not there is a layer of protective peritoneum on the outside of the emerging intestines. With the omphalocele, you'll see that you have herniation of abdominal contents into the umbilical cord, sealed by peritoneum, and because it's in the umbilical cord, it's present on the midline. You can see all the intestines here inside of the sac. Gastroschisis is free floating intestines in the amniotic fluid. And it's not covered by peritoneum. This is typically to the right of the umbilicus. Don't ask me why it's always on the right. I'm sure there's some anatomical reason that you know, a pediatric surgeon can tell you. I don't know the reason, but I have seen questions on this, interestingly, on UWorld. Where does the intestinal loops emerge from? Left or right of the umbilicus? It's on the right. Okay, and so how do you remember this? Just remember that giant O for omphalocele. Okay, and you know where I'm going with this. Just draw some intestines inside, and you'll always remember that for omphalocele, it is enclosed within peritoneum. So those are for our lateral fold. For our caudal fold, we can actually, if there's not sufficient closure, have exstrophy of the bladder where the ventral abdominal wall does not close around the bladder. These patients are at risk of adenocarcinoma. Meckel's diverticulum. This is our most common cause of intussusception in a young child. Most common cause of intussusception in a young child. So this is what's considered a true diverticulum because it contains more than one layer of bowel wall. Okay, when we talk about Zenker's diverticulum, when we talk about diverticulosis, that's typically 1 or 2 layers at most. Here we get multiple, in fact, all layers of bowel forming this diverticulum. Okay, this is caused by a failure of the vitelline duct to involute. This is important too. I can put stars on every line of this. This Meckel's diverticulum is pretty high yield for your exam. 2s of the population. It's twice as common in males, symptomatic by age 2. I've never been asked about these particular parts, but there is that rule of 2s here. Clinically, abdominal pain and bloody stool. There doesn't necessarily have to be abdominal pain. You can have patients that present simply with bloody stool and no other symptoms. Okay? It can be painless. It doesn't have to be painful. And the reason that there is blood at all is because this diverticulum can contain pancreatic tissue. It can contain stomach tissue. Okay? If it contains stomach tissue, it's going to be producing acid. Acid is going to erode. You know, typically we're talking about the ileum here. This is an area that is not used to having high acidity, right? Things are pretty basic by the time you get down here. Lots of bicarbonate. And so if you start introducing a bunch of acid, that's going to erode parts of the ileum and cause some bleeding, okay? That's why you see bleeding. So here, heterotrophic gastric mucosa, you can see pancreatic tissue, you can see all sorts of different tissues inside of here, and we can have ulceration and bleeding. Malrotation of gut, things you're looking for on a question about. Malrotation of gut. Ischemia and small bowel necrosis due to a volvulus. We're going to have bilious vomiting within the first month. Typically, they'll give you some sort of x-ray where you can see air in the stomach, air in the proximal duodenum, and then at some point, there's no air at all, okay? And so this is going to be due to a malrotation of gut. But these kids are going to be very, very sick. They're going to look very sick. Duodenal atresia, failure of small bowel recanalization. This gives us early bilious vomiting. We should see bilious vomiting. And here we're actually looking for a double bubble sign. Okay, so the double bubble sign, as Bob could probably tell you better than I could, my understanding is that you have some air inside of the stomach. You have the pylorus, which sort of squeezes things off. And then as you move into the duodenum, you have some air in the duodenum, and then because you reach this atretic portion, there's no longer any air. So that when you do your x-ray, it sort of looks like you have a single bubble here and a double bubble here. Okay, did I do okay? So? Okay. Okay, so we have a question for you here. Very much a giveaway. Okay, so you're right about that. It is diaphragmatic hernia. However, that may be the easy part of the question. The hard part is knowing what to do next. Yes. Good, excellent. And so, Osama, if you're watching this, or anyone else, I guess, potentially who's watching this, what you'll note here is on the x-ray, yes, there's a lot of beautiful things here in the patient history. If you don't need to read it, don't waste your time. You are on a timed exam. So what you're going to notice here is that for our right lung, it looks okay, right? Looks relatively normal. For our left lung, we're seeing all of these bubbling things in the left lung, and what these bubbles are loops of intestine, okay? And so these loops of intestine have made their way through the diaphragm and are now causing a complete collapse of the left lung and really just taking up space up there, all right? Now, okay, Bob did an excellent job answering this question, completely correct, and so, you know, I'm feeling like I want to challenge him. So, Bob, I have a question for you. I'll tell you one thing. This condition always happens on the left. Why is that? Why doesn't this condition happen on the right? Yeah. Yes. Yep. Exactly. You've got this pretty big, important organ on this side that intestines can't really push through to get to the diaphragm and then push through up into the lungs, okay? This is very much a test question. They love asking about this fact that, you know, you tend to see these, and I think you said this is a Boclodeck. Yep. And Morgagni is the one where it moves through the center or something like that? Anterior, yes. So they're essentially what we are discussing now are the different types of diaphragmatic hernias. There's Boclodeck, which is I think off to the side more, and then more posterior. So Boclodeck is posterior, Morgagni is more anterior. And so just the two places on the diaphragm where you can sort of have the initial sort of opening that can start to allow these intestines through. And once they are through, you know, you no longer have a closed system up here, and so the rest that can move up as well. Okay. I haven't heard of that. Cecum. I thought cecum was part of the bowel. So this is new information for me. Very interesting. They look like giant alveolar sacs, and so I can definitely, you're absolutely right, definitely needs to be on the differential for this one. Very good, very good. You know, Bob, it's great having you in this class. I just want to say that I'm so happy that you're taking this class with me, and I feel like I'm learning from you more than you're learning from me on a lot of these days. But one thing I do miss is a lot of times I get the opportunity to say, like, so what is this this worm-like formation growing into this infant's looks like umbilicus? What is this? This patient has some sort of worm growing, correct? Or I can. Yeah, it is. But I give my students a really hard time about it. I say, or there'll be someone's bladder is full on an abdominal X-ray, and I'll say, so what is this tumor that's growing in the pelvis? This large tumor you can see growing in the pelvis. What is that? And people are like, oh my God, that's a tumor? Like, what is it? I don't know. Like, what kind of tumor could it be? And then it's like, oh, that's the bladder, huh? You know. so I miss sort of having that. You're gonna know if I try and pull a trick. So. I can't do that now. So anatomy and physiology, we discussed a little bit about how for our sympathetics, they're going to follow what the arterial supply is. And so thinking about our sympathetics, let's see here. It doesn't really say the sympathetics, but essentially the sympathetics are going to be forming plexi that originate at the vertebral level, so T12 through L1, and that plexus will be called whatever, it goes along with the artery, okay? So if it's going to the foregut, thinking about the lower esophagus, the stomach, the duodenum, that should be supplied by the celiac plexus in terms of the sympathetics. It's going to be, parasympathetics is going to be vagus, of course. Midgut, superior mesenteric plexus, vagus, of course, for the parasympathetics. Okay, and then for the parasympathetics of the hindgut, it's actually going to be a pelvic supply for that. Okay. Remember that the sympathetics all flow from a certain part of our spinal cord. Sympathetics outflow from something called the thoracic lumbar outflow, whereby all of the sympathetic innervation of our entire body originates in the spinal cord from our T1 to L5, essentially, spinal cord. Essentially, that's where it all comes from. Okay, so you have sympathetic nerves that travel all the way up to the iris of your eye. Those nerves are traveling from the lumbar portion of your spinal cord. Okay, so just imagine that. All sympathetics come from thoracolumbar. Okay, parasympathetics can be coming from the pelvis. It can be coming from the vagus nerve, which originates in the brainstem. There's a lot of origins for the parasympathetics. However, sympathetics all come from that nice tight area. Okay. One other thing I want to mention on this slide is this idea of a watershed area. Whenever you hear watershed area, I want you to think about an area where if there, for some reason, there's a reduction in blood pressure, this is the area that's going to be affected first. Okay. And so in the case of the colon, you'll find that I never skip an opportunity to draw the colon. And so here, the SMA provides the proximal 2/3 of the colon, and the IMA provides the distal 1/3 and the distal colon as well. Okay, and so in this area, you sort of have the ends of one artery supply and the ends of another artery supply, such that if you start to have a little bit of a reduction, so we have the ends of our arterial supply. If you have a reduction in your blood pressure, both of the ends are going to be the first to lose oxygen, essentially. And so because these are sort of towards the end of the line for both of those arterial supplies, this is the area where you end up having ischemia in the case of low blood pressure, okay, a heart attack, or anything like that. This is where you have that. That's what's meant by watershed area. When we talk about neurology, we're going to talk about watershed areas again. Here's just a nice sort of diagram of our GI tract for you to look at and admire. Okay, some important ligaments. Falciform, this contains the ligamentum teres, which is the remnant of the fetal umbilical vein. Hepatoduodenal, beautifully named ligament because it tells you what it connects to, right? So from the liver to the duodenum, and this contains the portal triad. This is going to be our most important of the ligaments because it contains these three very important structures. Okay, what's in this portal triad? Common bile duct, very good, yep. And so this really has all of those three structures, and so in the case of a cholecystectomy where we're taking out the gallbladder, this is really one of the important things to identify before you really dig in and start doing your surgery. Okay, if you have a patient who's bleeding profusely from the liver and you're not sure what the arterial supply is to the liver, you can actually pinch off with your fingers or with a surgical tool. You can pinch this part, you can pinch this ligament and see if the liver continues bleeding. If it continues bleeding, that tells you that the liver has some sort of accessory blood supply. Okay, and so in the case of trauma, that it can be a useful procedure as well. Great, so part of the lesser omentum, yep, to control bleeding, great, and it connects the greater and lesser sacs. We have a number of other ligaments. None of these are particularly important. I think falciform and hepatoduodenal are going to be the ones that you want to make sure that you are comfortable with for your step 1 exam because they do tend to be asked about quite a bit. Okay, and so just a little bit of anatomy here. We have our celiac trunk, SMA, IMA, and all of the secondary branches for a number of other organs here. Our renal branches come off at about the level of between L1 and L2. When we get to L3, we have our inferior mesenteric, and at L4, we have a bifurcation into the common iliacs. which then separate into the internal and external iliac. External iliac will then go on to become the femoral. For the supply to our foregut, we have three important branches off the celiac trunk, which are the common hepatic, the left gastric, and the gastroduodenal. Wait, no. So we have our left gastric, our common hepatic, and the gastroduodenal. I feel like I'm forgetting an important artery. A splenic, excuse me. So left gastric, common hepatic, and splenic are the three branches of our celiac trunk. Even though I stumbled over that, you're not going to on your exam. Make sure you know those three. The three branches of the celiac trunk: left gastric, splenic, and common hepatic. Okay. The splenic is going to course behind the stomach, sort of following a tortuous course. That way, when we have a large meal, it doesn't rupture that artery. It has a little bit of room to spread there. And it's going to be giving off branches to the pancreas as it travels behind it. Okay. The left gastric is going to form an anastomosis with the right gastric artery, which comes around here and provides plenty of blood supply to the lesser curvature of the stomach. Our common hepatic is going to branch quickly into our gastroduodenal, which then gives a branch to our right gastroomental, which will anastomose with the left gastroomental, which branch from our splenic artery. The superior pancreaticoduodenal will give some blood supply, obviously, to the head of the pancreas, which is hanging out here. It's going to give some to the duodenum as well. There's also an inferior pancreaticoduodenal, which branches from the SMA. Okay. For our common hepatic, it becomes the proper hepatic after giving off the gastroduodenal. The proper hepatic will branch into the right and left hepatic, and then typically the right hepatic gives off the cystic artery, although there is some variability, natural variability in that. Looking at the SMA, you can see that the SMA provides quite a bit of blood supply. Not all of it is shown here. You can see a lot of the blood supply to the large colon. However, there's also, of course, the blood supply to the duodenum, the jejunum, the ileum. It really supplies the blood for all of that. That's just sort of, you can see through that here. And so in terms of the supply to the colon, we have our ileocolic artery, our right colic artery, and our middle colic artery. And those are the major branches to the colon. And so you can see why we call this area sort of a watershed area, because the last branch that the SMA gives off is middle colic, and then we have all of this distance that blood has to transverse to get to that watershed area. For our inferior mesenteric, it's going to be giving our left colic artery, the sigmoid arteries, and the superior rectal artery to that part of the rectum. Some of the venous supply, really importantly, I want you to be really comfortable with this idea of the portal system, which I'm sure you both are, but essentially this portal system is a parallel system with our systemic venous supply, whereby all of the blood that is draining from our GI tract first has to go to the liver before entering our systemic supply. That is the purpose of our portal venous system. If we eat a toxic berry, that toxin is absorbed by our stomach. It goes into the venous bloodstream. If it weren't for this portal supply, that toxin would go straight to our heart and then to our brain. However, because of this portal system, all blood leaving the GI tract first goes to the liver to detoxify it, and then joins the rest of the bloodstream. Okay? You are not going to need to label this diagram on your USMLE exam, and so if you're not super comfortable with the venous portal system, that's okay. Generally, they don't really pay too much attention to the venous system. I would say spend a little bit of time looking at it, because you never know what they could ask you about. But I haven't seen too many questions really focusing in on the details of the venous system, mostly just sort of the big ideas behind it. Okay, another diagram showing what the venous portal system is composed of. Zooming in on our pancreas, we can see here is our main pancreatic duct. We can sometimes have an accessory pancreatic duct. I believe that's called the duct of Wirsung, if I'm not mistaken. Here's our sphincter of Oddi here, the ampulla of Vater, where we have connection between the common bile duct and our pancreatic duct, such that the secretions of our liver mix with the pancreatic secretions and then are excreted into the duodenum past the sphincter of Oddi. The sphincter of Oddi contracts and relaxes, and definitely something to keep in mind. When doing surgeries or trying to catheterize this sphincter to take away blockages in the common bile duct or something like that, this can contract and relax. For our liver, the microstructure of our liver is very, very, very detailed and actually very interesting. And so starting here with our portal triad, you can see here's our portal vein, here's our hepatic artery, and here is our bile ductule. Okay, and so these will all sort of join with their larger cousins along the line. But what's important here, and what I want you to know, is thinking back to the hepatoduodenal ligament. All of these were carried by that ligament to the liver. Blood is flowing to the liver. We have our portal flow carrying venous blood to the liver, and our hepatic artery carrying oxygenated blood to the liver, and where bile is flowing the opposite direction. Okay, so the liver is creating bile and then excreting it in this direction. Okay, so that's sort of our first interesting thing. All of the blood that is coming to the liver is going to travel in this direction towards the central vein, central hepatic vein. And so as the portal blood is traveling in that direction, you can see that the sides of this tract are lined with hepatocytes, and these hepatocytes are going to be working double time to detoxify our blood. Okay, Kupffer cells are the macrophages of the liver. Okay, this is just like a classic question. They always love to ask about Kupffer cells for whatever reason. These are macrophages essentially. And what else can we say here? You want to be very comfortable with this structure because it ends up having some clinical relevance. And so we're looking at the exact same thing here. We see our hepatic sinusoid, we see our portal triad, and the blood flow moving towards the hepatic vein. Now, as blood is moving in this direction, we have zones here. And so our first zone is our periportal zone. Periportal zone is affected by things in the blood that kill hepatocytes. Okay, so think about viral hepatitis. Think about ingested toxins. If you're giving someone things that are very lethal to hepatocytes, the first hepatocytes to be touched are going to be the ones affected. Okay? As we move into zone 2, we're going to move a little bit further out from the portal triad in a circumferential manner, and this is really going to be affected by yellow fever only, and so that kind of makes it easy to remember. And our zone 3 is around the pericentral vein, and so here we're really talking about the area around that central vein. This is going to be affected first by ischemia. This makes sense, right? Because as you have a drop in blood supply, less and less oxygen is going to reach this vein, right? Because we only have this artery that's carrying oxygenated blood, and so less blood is going to reach this area. Contains a cytochrome P450 system, and for that reason, it's more sensitive to metabolic toxins. This is also the site of alcoholic hepatitis. Really, because this P450 system is here is the reason that we see its sensitivity to these particular aspects. Okay, any questions on this? No? Okay. And so inguinal canal and the different types of hernias. Looking at the canal here, what you can notice is we have our deep inguinal ring and our superficial inguinal ring. This is how we're going to start to orient ourselves. Now, this inguinal ring is important because it is going to allow the spermatic cord to travel from inside of our body to outside of our body and ultimately reside with the testicles in the scrotum. Okay, so what is this spermatic cord made of? So the spermatic cord is going to be made of a number of different aspects, including the internal spermatic fascia, you can see here, the cremasteric muscle and fascia, and the external spermatic fascia. These layers are going to be accumulated as the spermatic cord is traveling through these different layers of our abdominal wall. So as the spermatic cord travels through the transversalis fascia, it acquires its internal spermatic fascia. As it travels through the internal oblique, it acquires its cremasteric muscle. As it travels through the external oblique, it gets the external spermatic fascia. Okay, so this is why we have the mnemonic tie ice. I did have a question about this on my exam, so make sure you're comfortable with that, what each layer of the spermatic cord refers to in terms of layers of our abdominal wall. Okay, the other important thing here is the difference between direct and indirect hernias. For our direct hernias, those are going to be hernias of abdominal loops that are able to protrude through the abdominal wall and then force their way through one of these openings that the spermatic cord is traveling through to enter the spermatic cord and possibly even into the testicle, okay? And so direct hernia goes right through the abdominal wall. Indirect hernias go through the internal inguinal ring. And so with an indirect hernia, you have that loop of bowel that forces its way in through this internal inguinal ring and then ultimately makes its way to the exact same area, okay? And so in terms of remembering this, the way I always remembered it is that the indirect hernia goes in the inguinal ring, okay? Indirect hernia goes in the internal inguinal ring. Direct hernia just goes straight through the wall. It's direct, it just wants to go straight through the wall, okay? What is the anatomical marker between direct and indirect? That's going to be the inferior epigastric vessels. Bob is nodding because this is a classic question, right? They always love to ask this. Okay. Some of our retroperitoneal structures, a structure that is covered by this fatty protective layer. The mnemonic for remembering these is going to be our SAD pucker. Suprarenal glands, aorta, IVC, duodenum, pancreas, ureters, colon, kidneys, esophagus, and rectum. And these are important because if you have some sort of injury to one of these organs and you have, and that organ is bleeding, a lot of blood can accumulate in this retroperitoneal space without the patient having many symptoms, where you can actually have your patient go into hypovolemic shock without you even realizing that they're bleeding into their abdomen, okay? If they have a pre-peritoneal bleed, if they are bleeding out here, typically that's pretty painful for them and easy to appreciate on a fast exam with an ultrasound. However, when it's retroperitoneal, it's a little bit more difficult to pick up, is my understanding. Okay, and so next we're going to move into physiology. I'm going to take a pause here for 5 minutes, okay, if you need to get a drink of water or anything like that, and we'll resume at the 5-minute mark, 9:05. Okay. So let's get started here. This is a nice chart, I think, containing some details about the different secretions from different parts of our GI tract. Our salivary glands secrete a hypotonic solution, thank God. Otherwise, our mouth would constantly taste salty. Our salivary glands, I should say, also secrete two important enzymes, alpha amylase and lingual lipase. These two enzymes will begin the digestive process. They will both be deactivated by the acidic conditions inside of the stomach. However, for the period of time that there's food within the mouth, they will be hard at work breaking that food down. And so sleep, dehydration, and atropine all decrease secretions here, okay? And so this atropine is always important. Whenever you see this atropine, you're obviously thinking that that is the anti-parasympathetic, right? And so if we're saying that atropine decreases secretions here, that means parasympathetic must be very active here. Gastric secretions, hydrochloric acid, pepsinogen, and intrinsic factor, okay? The only thing that you need of these three, we always talk about the gastric acid, oh my God, it's so acidic in the stomach. The only thing that you need from your stomach to be able to live is intrinsic factor. If you lost every single cell that made pepsinogen, you would continue to live. If you lost every single cell that made acid, you would still continue to live. If you lost every single cell that made intrinsic factor, like pernicious anemia, right, you would not be able to live. You would get severely anemic and die, okay? So this is really the only thing that your stomach makes that you need to live. Gastrin, ACH coming from our vagus nerve, histamine, parasympathetic nervous system, all increase secretions. Decreasing secretions, if there's already hydrogen in the stomach, there's going to be some negative feedback there. Chyme in the duodenum, so if there's already traffic a little bit further down the highway, that's going to cause some slowdown of the gastric secretions. Somatostatin, atropine, cimetidine, and omeprazole, classic PPI. Pancreatic secretions, of course, are going to be very, very basic. And the reason is because you're getting that very high acidity coming from the gastric secretions. You need something to even that out before it gets to the jejunum and ileum, where you have more sensitive tissues. We're going to have lipase, amylase, protease, trypsin, a number of important pancreatic enzymes being secreted here. Don't forget about the enzymes that are part of the wall of the duodenum as well. There's brush border enzymes that will function in absorbing things like disaccharides, okay? And so there's going to be a number of different enzymes at work in the duodenum. The duodenum to me is kind of like the proximal convoluted tubule. It's a magical place, right? A lot of things are going to be absorbed in the duodenum. So secretin, CCK potentiates secretin, our parasympathetic nervous system, CCK, and the parasympathetic nervous system. Biliary secretions are going to be our bile salts, bilirubin, phospholipids, and cholesterol. CCK causes a contraction of the gallbladder and a relaxation of the sphincter of Oddi. I want you to get a tattoo when you have some free time this weekend of this fact. CCK contracts the gallbladder, relaxes the sphincter of Oddi. If it's tattooed on your body, you won't get in trouble for cheating. Okay, at least I don't think you will. If you do, you know, it was worth it, okay, because that's going to be a badass tattoo, all right? This is a very important thing and something they love to ask about. What does CCK do? Contracts the gallbladder, okay? And so in terms of decreasing secretion, if you resect the ileum, this is sort of an interesting phenomenon. If you take out the ileum, this is going to decrease the secretion of bile acids. And the reason for this is because something around 80% of your bile acids are recycled. You secrete them from the liver, they enter the duodenum, they break down your fats, and then when they get to the ileum, they get reabsorbed through the portal system and return to the liver to start the whole process over again. 80%, that's a lot. And so if you take out someone's ileum, say they have Crohn's disease or something like that, you got to remove the ileum. That patient is going to be losing 100% of their bile salts and ultimately will stop having biliary secretions and have a lot of trouble breaking down fats. Okay, and so those patients are going to be at risk of fat-soluble vitamin deficiencies. They're going to be at risk of calcium deficiencies. There's a lot of crazy thing that happens when you take out someone's ileum. So great. So in terms of the stomach, the parietal cells are the most important cells of the stomach. Okay, you have these other cells called chief cells. These are the cells that think they're hot stuff. They're saying I'm the chief. I'm all that. The truth is they're not terribly important at all. The chief cells are not important at all. All they do is secrete pepsinogen, which initiates the process of protein digestion. It doesn't even do the full process. Okay, so chief cells, these are like lame chief cells. Parietal cells do all the work. They secrete acid. They secrete intrinsic factor. Okay, intrinsic factor is required for absorption of cobalamin. Cobalamin will not be absorbed until you get to the ileum, but this is obviously something that you need for red blood cell health. Okay, the mucous neck cells secrete mucin, which will protect the gastric mucosa. The antrum of the stomach is responsible for secreting gastrins, somatostatin, and to start to make more basic the gastric contents. So what stimulates it? We've got ACH coming from our neurocrine, thinking about the vagus nerve here. We have histamine, which is a paracrine release from the enterochromaffin-like cells. They do like asking about these. The enterochromaffin-like cells secrete histamine, and then histamine will go to nearby cells to increase secretion of acid. Gastrin is released by G cells into circulation and reaches parietal cells by an endocrine mechanism, meaning that, so we said histamine is paracrine, so it's just going to locally diffuse to cells. Gastrin is actually being secreted into the blood supply, and you'll find gastrin in, if you check a venous sample from the pinky toe, you're going to find a little bit of gastrin, and the reason is because it's an endocrine hormone, just like testosterone is an endocrine hormone, so is gastrin. And so what you see here is that it's sort of not local diffusion. Great. What else can we say here? Yes, so here's a beautiful chart from your first aid book showing the important secretions of the stomach, the different source in terms of cells, and some important notes about each. More different sorts of hormones that you may hear about. Not all equally important, but they are all present there if you'd like to review that. Okay, and so I really like this diagram showing the different stimuli for release of the different things inside of the gastric system and the duodenum. And so what we're looking at here is what causes release of acid. Okay, let's start here. What causes release of acid? Acid is, of course, coming from the parietal cells. These are the important cells of the stomach. And the first trigger that we see is acetylcholine coming from the vagus nerve. Okay, and so when that parasympathetic system gets going, we're going to have release of more acid. Great. Second thing that is going to stimulate secretion of acid is going to be our gastrin. Gastrin is going to be coming from our G cells, which were stimulated also by the vagus nerve. Okay, vagus nerve is going to cause release of GRP onto a G cell, releasing gastrin, which will then go to the parietal cell and cause release of acid. Gastrin is also going to our enterochromaffin-like cells, stimulating release of histamine, and histamine potentiates the release of acid, meaning it accelerates, it increases the release of acid from those parietal cells. Pepsinogen coming from our chief cells. Okay. As we move into the antrum's role is to protect the stomach. Okay, so it's going to be releasing mucus, which provides that protective lining. It's going to be producing somatostatin from D cells, which cause a reduction in release of the gastrin and everything else. Okay, so somatostatin is an inhibitory type hormone. And so the antrum is very, very important for protecting the stomach and starting to make things a little bit more basic before you get to the duodenum. Now, thinking about what can go wrong in the stomach, imagine you have some sort of bacterial infection to this part of the stomach. Say only this part of the stomach is infected. Okay? In that case, we would be very worried about ulcers forming here in the duodenum, because what we just said is that this part of the stomach is responsible for helping make secretions that protect the duodenum. And so a bacterial infection at this particular location would cause duodenal ulcers, okay? And I think you probably know what I'm hinting at here, which we're going to talk about in a couple slides. Okay, so biliary secretions, digestion, absorption of lipids. We mentioned that it is produced by the liver, of course, when the bladder contracts and sphincter of Oddi relaxes, secondary to the 3-letter hormone CCK. Bile will be ejected into the duodenum. It's going to emulsify lipids, prepare them for digestion, and solubilize products of lipid digestion into micelles. So hepatocytes are going to make the bile. Great. It travels to the bile gallbladder. This is essentially sort of repeating what we mentioned in the last slide. And here's showing our recycling of bile salts. Okay, making their way down to the ileum and then through the portal hepatic vein. Excuse me, I think I said 80 earlier. According to this diagram, 95% of bile salts are reabsorbed by the small intestine, i.e. the ileum. And so you can see that that is pretty stinking important that your ileum is able to do that. A resection of the ileum is going to interrupt that recirculation of bile salts, and so bile salts are then going to be excreted into the feces. We're going to lose our bile acid pool and ultimately end up with decreased absorption of dietary lipids, steatorrhea. Now, what types of patients need an ileal resection and then may need subsequent bile acid supplements? Okay, so in malabsorption syndrome, could you be a little more specific? Mm-hmm. Mm-hmm. Yes. Mm-hmm. Good, yeah, so our inflammatory bowel diseases, especially Crohn's disease, ileal resection may be called for in those cases. Yep, absolutely, very good. So in terms of our bilirubin metabolism, we haven't really discussed this yet, and it does have some important things to reflect on this particular topic. Heme is turned into heme oxygenase by heme oxygenase to biliveridin, which is converted to bilirubin. Okay, so we have a breakdown of a red blood cell. It releases its hemoglobin. The heme is taken away from the globin. It's broken down into bilirubin. Bilirubin is going to be carried in the blood, bound to albumin. It's going to be extracted by the liver, conjugated to glucuronate to form bilirubin glucuronides, okay? If it's conjugated to glucuronate, we call it what? Conjugated bilirubin, right? Or you may also hear it called direct bilirubin, same thing. If it is not conjugated to glucuronate, we call it unconjugated bilirubin, or you may hear it called indirect bilirubin. Okay, but in either case, the important distinction between these two is that direct bilirubin can be easily extruded through the bile system, whereas indirect bilirubin is going to precipitate and not go anywhere. Okay, indirect bilirubin is unconjugated and water insoluble. It's going to precipitate and cause problems. Direct bilirubin, it's water soluble. It'll join the bile and leave through the bile. It'll join the bloodstream and leave through the kidneys. Direct bilirubin is what we want. Indirect bilirubin is not what we want. Okay, so sort of looking at that breakdown from red blood cells to heme to unconjugated bilirubin, that is going to bind to albumin. Okay, while in the bloodstream, we don't want it floating around by itself. UDP glucuronosyl transferase. This is a very important enzyme for your step 1. I know I say this all the time, and I need to stop saying it so much, I think. I only say it when I mean it, and I really mean it here, that you are going to have a question on your step one that asks you about UDP glucuronylyl transferase. Okay, if you don't have a question on that, I will send you a check for $100. Okay, and this is being recorded, so you know I mean it. Okay, you are going to see the name of this enzyme on your exam, or I will send you a check for $100. Okay, and that's going down in history. Okay, so this enzyme is very important. A lot of things can happen, when we think about congenitally low levels of this enzyme. We think about normal newborns having a physiological low level of this enzyme, and they end up having some level of jaundice because of that. We think about patients who, their liver no longer works, and so the level of this enzyme drops. So they cannot conjugate bilirubin. And so it's a very, very important enzyme, okay? Not many places in the body do you just have one enzyme doing a job so important that if you lose it, you die. This is one of those cases. And so it's going to convert unconjugated bilirubin to conjugated bili, which is going to be water soluble. In terms of the gut, it's going to be converted into urobilirubin by gut bacteria. According to this, 80% is exerted as feces and 20% is reabsorbed. So I don't even know at this point what is reabsorbed, what is not reabsorbed. Hopefully that's not on the exam. My understanding is more of it is reabsorbed than is excreted, but I think double check on that because there's multiple different things in this lecture I'm finding out right now. And so in terms of the gut, we're going to have some that re-enters the bloodstream and is excreted through the kidneys as urobilin, and this is what's going to give our kidney the yellow color. Okay, so bilirubin can leave through the kidney as well. And then 90% is going to go through enterohepatic circulation. I'm totally confused about these numbers at this point. But there is a significant portion of the bilirubin that is going to be recycled. Okay, I think I realize what's going on. So bile salts, you have 95% reabsorbed. Bilirubin and the conjugated bilirubin is not the same thing as bile salts. Okay, and maybe this was obvious to you, I'm just figuring this out. And so for bile salts, you reabsorb 95%. For your bilirubin, you're not going to be reabsorbing much. 80% is going to be excreted, 20% reabsorbed. Okay? All right, I think we're all on the same page now. Yeah, this one's a little bit easier for you, Bob. So I'm going to make it a little bit tougher. Let's say instead the patient had biliary atresia. How might this look different? Good, excellent. Excellent. So essentially with biliary atresia, you're not having formation of the bile system within the liver and without it, and because of that you end up having an accumulation of indirect bilirubin in the blood, and indirect bilirubin can definitely improve bacteria's chances of starting an infection inside the bloodstream. And so you're absolutely right, look for sepsis, look for that jaundice. Excellent. Yes, this is going to be your Hirschsprung's disease. And so walk me through it. Why do you say Hirschsprung's? Yeah, so when you have a baby, exactly. So when you have a baby that does not pass meconium, it's kind of a nice thing because you really just have two big things in your differential. Number one is cystic fibrosis, and number two is going to be Hirschsprung's. There's other things that can do this, but you know, you can have some sort of atresia in the intestinal tract. If you have atresia, obviously you're not going to pass meconium because there's no real GI tract to pass it through. There's a number of other causes of failure to pass meconium, but typically, you know, at least in the context of USMLE, these are going to be the top of your differential. Cystic fibrosis and Hirschsprung's, and you got to figure out which one it is. Here they tell you a sweat test shows no abnormalities, and so right off the bat, you're knocking out cystic fibrosis, right? Seeing the large dilated segment of transverse colon. Now, why do we get a dilated transverse colon? Good, excellent. And so, so you're absolutely right. I'm sorry to cut you off, Bob. And so the distal parts of our colon are going to be totally shrunken down, and the reason is for this lack of ganglion cells. And the proximal part is going to be totally dilated with just the stool load. That's where the mech is. This is where the meconium is. It's just totally dilated with all that extra stool. You can have these patients can get very, very toxic, and because of this stool load. So not a good thing. Interestingly, there is some association of Hirschsprung's disease with Down syndrome. And guess what? When we talked about the type of cardiac defects you see in Down syndrome, I mentioned to you that all of the cardiac defects in Down syndrome are associated with neural crest cells. That's why you see the ostium primum right next to the endocardial cushion. That's why you see the defects in the ventricle close to the endocardial cushion. It's also the same reason for the facial abnormalities you see in Down syndrome is because of neural crest cells. It's all due to neural crest cells. Guess where ganglion cells come from? Okay, so what happens is normally neural crest cells have an origin and then they move proximally to distally. Okay, so neural crest cells progress. They you know, find little homes here along the colon. They find little homes. They make their way. In the case of Down syndrome, these neural crest cells don't quite make it all the way to that distal part of the colon. Okay, and so from here on out, there are no neural crest cells to form ganglion cells, and there's no sort of nervous tissue in this part of the distal colon. Okay, and so that's sort of an interesting thing that I usually spend way too much time talking about. Excellent, yes. So this is a question about what is the acid-base status in the blood of a child with pyloric stenosis. They are vomiting up all the acid in their body, and so they're going to have a metabolic alkalosis, and that you can always check for on an ABG by an elevation of bicarb. Okay. Mm-hmm. Excellent. Yes. So Bob says that it was between angiodysplasia. Just breaking down the word here, we have a dysplastic growth of blood vessels, essentially. And then he was also between volvulus and intestinal obstruction. Okay, and so we see a child who's presenting with black stool, and our first thought has to be, okay, this might be melena, right? This might be digested blood, and so. Of all of these options, those are really the only ones that make sense. Adhesions don't really make sense. Adhesions are more common in patients that have surgery. Pancreatic insufficiency doesn't make sense at all. There we would see something like steatorrhea. Intestinal herniation, I guess this one could be a potential answer here. If you had a herniation and part of that loop of intestines got stuck in the herniated area and became ischemic, you could potentially have a bloody stool secondary to that, but again, unlikely in a 15-month-old, especially once they tell you about all this protectate junk. And so intestinal herniation's out, so we're down to angiodysplasia, volvulus, and intestinal obstruction. And so why do we have technetium protectate uptake? What does this mean? What are they telling us with this? So, not necessarily abnormal bleeding. What it really tells us is if there's abnormal tissue. Okay, and so this ectopic uptake is telling us that there's somewhere in the GI tract that is metabolically active in a way that it's not supposed to be. I don't know the details about technetium 99, how exactly it works. I need to read up on it again. I knew it at one point, but I totally forgot. Uh-huh. Uh-huh, uh-huh. So interesting. So in clinical practice, Bob is saying that technetium 99 is used to identify a location of abnormal bleeding when probably the GI team is totally stumped and doesn't know where the blood is coming from. Instead of angiography, yes. And so, in the case of USMLE step 1, that is never going to be the reason that you see this technetium 99. Okay, that is never going to be the reason that they tell you about technetium 99 about abnormal bleeding. Technetium 99, they're going to talk to you about, in this case, which is they're actually talking about Meckel's diverticulum. That's why you have this ectopic uptake, is because you have those metabolically active cells within the Meckel's diverticulum. You'll also hear this talked about in the context of thyroid pathology and things like that. I've seen this talked about as well, but typically not for identifying the location of abnormal bleeding, although you're absolutely right, in real life that is what it's used for. Okay, in this case, seeing this that the fact that the child is irritable with palpation of the right lower quadrant tells us that there is some sort of damage happening, right, and discomfort. Angiodysplasia is painless, right? This is a dysplastic growth of vessels that is painless, and this is the most common cause of rectal bleeding in adults. The most common cause of rectal bleeding in adults is angiodysplasia. Older adults, elderly patients is angiodysplasia. Okay, it's not colon cancer, it's not hemorrhoids, it's angiodysplasia. Okay, so that's very important for our elderly population, but not definitely for our pediatrics. And so we must know that he is talking about Meckel's here, and although typically we talk about Meckel's causing intussusception, which is different from volvulus, It could potentially also cause volvulus. You're giving, you're causing there to be somewhere that the intestines can rotate around. That can lead to volvulus as well. Okay, and so this is going to be our answer here. By elimination and by reason, this is going to be our most likely complication. Okay? Great. Yes, it is. Excellent. What is the... That's a great thought. Mm-hmm. That's an excellent thought. Good. Yeah, so, I mean, I like how you use logic there. The presence of an anal dimple is kind of cluing us in that, the sacrum may be involved here. If the sacrum is involved, then it makes sense that you would want to say vertebral defects as that's sort of the terminal part of the vertebrae. So the precise condition they're discussing here is something called Vactorel, which is a syndrome. It's an association that currently is unknown what causes it exactly. You'll also hear it called Vater syndrome. Vater is essentially without the limb abnormalities, but everything else is there. So for Vactorel, we have vertebral abnormalities. We have anal dimple, or is this rectum? Cardiac defects. Tracheoesophageal fistula. Renal abnormalities, and limb deformation. Okay, so this is going to be anal atresia. Okay, so I know my writing is not the best, so I'll just review those. Vactoral syndrome is the presence of vertebral abnormalities, anal atresia, such as in our patient, cardiac abnormalities, such as in our patient, tracheoesophageal fistula, renal abnormalities like horseshoe kidney and things like that, and limb deformities. Okay, you can see multiple extra digits on a single hand, etc. Okay. Great. Not the hepatic bile duct? Mm-hmm. Yes. Portal triad is the best answer. And this answer is wrong. This answer is wrong because the hepatic bile duct is not in the portal triad. The common bile duct is within it, right? Yeah, good. Excellent. You're absolutely right. Portal triad. Very good. Good. So since you got that question right, Bob, I want to ask you a question that is probably more step two, definitely more step two. But what is the typical size of the common bile duct. Uh-huh. Oh my God. Mm-hmm. Wow. I love radiologists. That is very impressive. Okay, so that's going to be it for today, Bob. A little bit of a shorter lecture today. Any questions I can answer for you before I let you go? Sure. B1 and B2? Oh, for bilirubin? Oh, I never even heard that. Yeah. That's a great question. Uh-huh. Oh, okay, hold on. Uh-huh. Oh, so... Oh, I see, okay. Interesting. I never knew that before. I learned something new. That's very cool. So the B1, okay, I found it. Yeah, so B1 is unconjugated and B2 is conjugated. Mm-hmm. Yeah. Yeah, you're welcome. So you can kind of translate it back, into the way that you learned it now. The old school. Okay, great. Thank you very much, Bob, for your kind words, and I look forward to seeing you on Thursday. All right, take care. I do too, yeah. He'll be there Thursday for sure. I'm going to email him again and send him a link to this so we can study up. Okay? Take care. Good night.